Hello everyone and welcome to today's webinar, Trauma Verification's December Q&A Web Conference. When joining today's webinar, you selected join either by phone call or the computer audio. If for any reason you would like to change your selection, you can do so by accessing your audio pane in your control panel. I would now like to introduce Molly Lozada, Trauma Verification Program Manager.
Thank you. And thank you everyone for joining today's web conference. I'd like to introduce our team. We have Tammy Morgan, myself, Julia McMurray, and Rachel Sanchez. And just want to read a couple of things. Continuing education. To qualify for CE, you must attend at least 60 minutes of educational content. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar, ending with instructions on how to obtain those. If you have any questions throughout this entire process or webinar, please feel free to email us at cotvRC@facs.org. Our goals for the webinar are to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient, understand the process and standards involved in an ACS Trauma Verification site visit, and how following these will process. So with that said, let's get started. A couple of things to have on hand. In hand is the orange book if you have a hard copy. If not, there is a PDF version available online. Through this webinar, there's going to be a section on CD-related questions that you can follow along with the manual or the PDF version. We do have some updates, which is the clarification document and the verification change laws, which are available on our VRC resources link. Just a little information about the clarification and verification document and how that works. The updates for the monthly verification change log and clarification document for October and November has been completed. So an email was sent to those trauma program managers, trauma medical directors, and some additional folks that we have kept a list on. So that was sent, I believe, 2 weeks ago. If you want to view those updates and changes, again, they're posted on our VRC resources links. Going forward, changes to the criteria will be published in the verification change log as opposed to in the clarification document. We're only going to use the clarification document to capture any nebulous content to those clarifications, or those standards rather. This is what our clarification document looks like. Again, there's monthly updates sent, primarily sent in the middle of the month. So the next one's going to go out about the 16th of December. I'll send an update to everyone. If you have not received an email from us, please email us at cotvRC@facs. I do want to mention that because it's coming from a different web or different email address versus my own personal email address, to look into your firewall to see if maybe they're being captured in your clutter or in your junk email. Our verification change log, again, this is updated and sent in conjunction with the change, with the clarification document, so they'll both be sent together. I do want to mention that if there are any changes to the clarification document or that of the change log, in the body of the email, I will note those changes. So there'll be a section for clarification and a section for change log. Recordings of the webinar are kept, and they will be posted within a week following the webinar, and they are found on our VRC resources webpage. This disclaimer, all questions are pulled directly with the content. Any typos, 2017, and we'll go ahead and send out an email with this information. More announcements. The 2017 NTDS Data Dictionary is now available, and you can go ahead and download a copy of that from the NTDS Dictionary website. Some scheduling reminders, and I'm going to go ahead and ask Rachel to talk about this.
Good afternoon. As Molly mentioned, I'm just going to go over some scheduling reminders, and we could start off with the site visit application. Your center site visit application must be received in the ACS office at least 13 to 14 months in advance of your requested time frame or the current expiration date. Since we receive a multitude of applications, having it in this early will basically hold your spot in the time frame you're requesting. Also, in addition, this provides your center plenty of time to prepare and complete the online PRQ. At this time, all of 2017 has been closed to scheduling, and January 2018 has just a handful of spots available. And you can find the site visit application at the link listed.
Thank you, Rachel. I'm going to talk a little bit about the orthopedic traumatology leader form. Anita and myself field quite a bit of questions for those combined trauma centers. And what I want to say about this is that we are tracking these forms so that way in 3 years from now, if you have the same OTL leader, we already have that information captured. So the confusion comes from, let me backtrack a little bit. For level 1 adult or level 1 pediatric trauma centers that are coming up for a site visit or have a visit in the next year or so, please be sure to complete the OTL form. That's also on the application site webpage, so you can send those in together. And then what I want to say about this is for those trauma centers that have separate visits, such as a level 1 adult trauma center that also has a level 1 pediatric trauma center, possibly having the visits in tandem or combined, and you share the same adult or the same OTL surgeon, whether it's adult or the pediatric. We want the form completed for both. So if the adult level 1 trauma center is going to have their visit, we want them to complete the entire form in its entirety, whereas for the pediatric program, they would only have to answer questions 1, 2, 3. If it's, or vice versa, if the pediatric trauma center was to have their visit first, then we would ask them to complete the entire form, and then the adult trauma center can go ahead and complete questions 1, 2, 3. If you're unsure if the adult or the pediatric trauma program has completed a form, you can always reach out to us at the COT VRC inbox, and Anita or myself will go ahead and let you know if we have a form on file for that trauma center. So I just want to stress that you can share the OTL leader for those combined centers, and if you do, we are going to ask you to complete a form for that OTL.
Okay, so the PRQ online access. After the VRC office receives your site visit application, the trauma program manager that is listed on the application will receive an email receipt acknowledging that we received it. Also, very important, in that same email receipt will be your logins for the online PRQ. So you have access to the PRQ at that point, right from the beginning. Okay, site visit application payment. Please do not send in payment with your application. You'll receive an invoice 60 to 90 days before your visit, which will include the fees for both the site visit and TQuip. Afterwards, your center will be invoiced annually for the quality program fee for the remainder of the verification cycle. This annual fee does not include fees for additional reviewers. and you can find the fee structure at the following link. And then for scheduling the site visits, you should receive your site visit dates by 90 days before your scheduled visit. Sometimes you'll receive it earlier, and on occasion it may be a little later. If it's after the 90 days, feel free to send us an email to check on the status. Ideally, all visits will occur during your requested time frame. So during scheduling, when a lead reviewer is available for your visit, I'll first contact the trauma program manager to confirm that the dates will still work out. So the dates won't be a surprise to you.
Okay, thank you, Rachel. So we're going to move on to general questions. So let's start with, I had a question on the recordings, and I know we say it in the beginning, but I also want to reference where this can be found and how it looks like on our web page. So yes, our recordings and slides, if you will, presentation are available on the VRC resources link, as you see here. Here's a snippet, if you will, of how they line up in the web page. So it has the June recording, the July, and August and September, and shortly we'll have December's recording on there. So I'm going to ask Julia to talk about TQuip.
Thanks, Molly. So we had this question about what is the best method for demonstrating the use of our TQuip data during our site visit? And this question was from a Level 2 center. So we reached out to some of our reviewers, and they gave us some insight into how they're using your TQuip data and what they want to see from you during that site visit. So one thing reviewers want to know is, are you using TQuip to enhance your current PI that you already have in place? And have you used your TQuip reports to identify some areas for improvement and then put in place a process to improve those areas? Are you closing the loop? And are you sharing your data beyond just your core trauma team? Have you reached out to your orthos liaisons if there are ortho problems? Are you sharing this with your hospital QI and so forth? So again, what's required is just that you're participating in TQuip, but these are some things that reviewers have said that they like to see and ask centers for when they come in and visit and look at their TQuip report. And this center asked, is there a time frame for when TQuip data will be incorporated into the PRQ? So in the current version of the PRQ, we're not going to be injecting TQuip data, but we have a project set in place to put forth a new version of the PRQ over the next 2 years. And in that new version, we will be putting in some things that you already submit to TQuip. So you won't need to put in, you know, how many hospital beds you have multiple times. You won't need to look at the number of you know, hip fractures that you have or whatnot. You won't need to put that into the PRQ because we already have that data in TQuip, and that will come in the next iteration of the PRQ. And this center is asking for combined adult level 1 and pediatric level 2. When will pediatric TQuip be a requirement? So right now, there is no requirement for these type of combined centers to be in both adult and pediatric, and we don't have a plan to do so, and I'll tell you why. And of course, you're welcome to join both adult and pediatric TQuip, but it is not required. So for these combined centers that are the level 2 peds with an adult level 1 or 2 program, you're already meeting the requirements of CD 15.5 through your adult center. And the CDs that you have to comply with to be a level 2 pediatric center does not include CD 15.5. Therefore, you're not required to participate in pediatric TQuip. However, centers that are a level 1 peds with a level 1 or 2 adult center are required to be in both adult and pediatric TQuip, because when you're a pediatric level 1 center, CD 15.5 is one of the requirements you have to meet to be a level 1 pediatric center. So those centers are required to participate in both adult and pediatric TQuip.
Thank you, Julia. So I had a center ask what are the top 5 weaknesses or CDs that trauma centers are experiencing with the release of the Orange Book. So we came up with a top 4 criterion deficiencies that between Megan and myself have been seen over time. And we're just hoping that it's just a matter of clarification that will resolve a lot of these deficiencies. So as a lot of you are aware of, excuse me, CME is a huge area of concern, just meeting the requirements and what that entails. Peer review attendance, as you know, is 50% peer review, but we've clarified that and made some exceptions now to allow a predetermined surgeon or physician to attend in place of the liaison. Universal screening for alcohol use is another area that we see. And there's clarification on that as well, that it is for all trauma-admitted patients. Loop closure is not as common as it used to be with, or common as, if you will, with such as CME or peer review, but there are some issues that we're still seeing with loop closure and in the sense of documentation. So there's clearly not enough documentation. For example, if the neurosurgeon had a consult on a trauma patient, was there any discussion about the care of that patient, and is that documented in somewhere in their case review? So, you know, again, with loop closure, if there's any issues identified during the peer review meeting, how is that tracked? Is that being resolved in what practice, or what is the trauma center doing to address those issues, and how is that closed? So those are the top 4 that we've been seeing, and we are going to start tracking these as we move forward. Question about advanced practitioners. I know we talk about this in every session or every webinar, but it's actually, some of the questions are really good because it's different based on that specific trauma center. So the question here is, do all PAs or advanced practice providers, again, those names are interchangeable for us, need to have APLS regardless if they participate in activations? So not exactly. So if the advanced practice provider or PAs or APRNs who are not involved in the trauma team activation, or let's just say they are part of the trauma team activation team and they're just a scribe, they would not be required to be current in APLS. And again, this is also on the clarification document. So this question also related to advanced practitioners. So if your EDPAs are APLS certified but not part of your trauma team activation response team, are they, do we expect them to get the ED physician involved, and do you expect to see documentation in the form of attestation by the ED doctor that they were made aware of the patient's care plan? And the answer is yes. So if the APAs or APPs are managing trauma patients during the non-trauma tier activation, which we also call it the consult level, it is required to document any discussions involving the patient's care with the physician or the trauma surgeon. So again, that also leads to loop closure and documentation. Questions about pre-review questionnaire. So I had a question from someone asking about the question about what is the percentage of TBI patients within 24 hours, and how would that be, what would we consider the denominator? So from the PRQ, it's question number 6, and it asks, what is the percentage of severe TBI patients that had an ICP monitor inserted within 48 hours of admission? And this is during the reporting year, so we're just looking at the reporting year. So the denominator would be for all TBI patients during that year. So how many of those during that year had an ICP monitor inserted? Pre-review questionnaire, pediatric admission. So the question comes from a trauma center, a level 3 trauma center, asking, does this include peds with single system ortho injuries that go into the OR and then go home? If the single system injury meets the NTDS inclusion criteria, it should be counted towards the PRQ volume requirement. So the answer would be yes. Pre-review questionnaire about pediatric surgery. I know there's been a lot of confusion on the PRQ, and we are, again, working on addressing these concerns. And I'm hoping that this slide here is helpful for those trauma centers that have concerns about completing the PRQ. So the question comes in from a level 3, and this can be from a level 1 or a level 2 trauma center. And the question is, if they occasionally admit pediatric patients to their adult ICU, do we need to answer the TQuip PRQ questions? And the answer is yes. And basically, if you are a level 1 or level 2 or 3 trauma center, even though you're not seeking pediatric verification, if you admit pediatric patients, let's say it's just 1 patient or 2 or 200, we want you to complete the PRQ as follows. So again, in the PRQ, in the section where it asks level of review, it's a level 1, level 2, and level 3. And if your facility treats adults and children, you want to go ahead and select it, because what the PRQ is programmed to do is it will display questions that pertain to that patient category. And if that is the case, when you get to the surgery, the pediatric surgery section, we want you to complete the following. Section A, which is question number 1, it asks, what is the age that your trauma center treats for children? Section D is your splenetic injury table. And Section C, which is your pediatric trauma admission entire. So you want to complete the entire section. And in this section, you want to only enter your pediatric data. And then you're going to go ahead and skip to Section 11, which is collaborative services, which is also encompasses ICU and the PICU section. So you want to go ahead and answer those. And again, if your trauma center selected adults and children, only those questions that pertain to your trauma center will be displayed. That's why it's important to go ahead and select that category. Pre-review questionnaire, contingency plan. So this is coming from a level 1 trauma center, asking if they are required to have a contingency plan even though they don't divert or transfer their patients. And the answer is yes. And for reasons such as, you know, what if the neurosurgeon's encumbered, is in surgery, and another patient comes in, another neurosurgeon patient comes in, or there's a disaster and you need multiple neurosurgeons on hand or on deck, or your CT scanner is down, or there's not enough beds, or flooding. So we need a contingency plan in the event these situations occur, and you would need to go ahead and divert or transfer those patients to another trauma center. So it is important to have a contingency plan, even if you're a level 1, which the case to transfer a patient is going to be on rare occasions. Pre-review questionnaire question. Appendix 1 versus 14. I know this is going to be a little confusing, so I hope this slide is helpful. So the question comes from a level 1 trauma center. It's actually a level 1 pediatric trauma center asking if they can disregard Appendix 1 versus 14. And for those of you that have completed a PRQ, know that Appendix number 1 is for the trauma medical director, that being either adult or peds, and Appendix 14 is primarily for a pediatric trauma surgeon, trauma medical director, and they're the same. They actually look the same. We just titled them differently. And although both of them can be completed if you like, you're just duplicating it if you're level 1 peds, but you can use Appendix 1 or 14. We want you to use Appendix number 1 only because it's the first one that comes up, and sometimes it'll get skipped. The last one will get skipped because it is the last appendix in the deck. So if you do 1 versus 14, it's acceptable. It will do the same. Question about documentation for consult times. So the question is, what is the best method for capturing consult times and urgencies? So this will depend on the hospital system or what is in place at your hospital. So there are some trauma centers that have the physician or the residents or their advanced practice providers, mid-level providers document both the time of notification, time of bedside assessment, along with documentation on the trauma flow sheet. a trauma center should develop a plan where the information can consistently be retrieved by the registry staff, because this is something the reviewers are going to want to see in their case review. Then this is something that you can PI in your process for any delays in care. VRC updates. I did a segment on this last month, and I just want to bring this discussion back around, or this presentation back around, because we've had a few more updates to this. And so there was updates on CME. In the past, we didn't accept CMEs from boards, whether they were initial boards or recertification. This has now been accepted and approved. So to meet the external CME requirements, this is for your liaisons and your trauma medical director, 33 hours from the initial board certification or the recertification will be accepted as trauma or critical care external CME. So this will count for the trauma surgeons, the orthopedics, the neurosurgeons, and emergency medicine. I do want to clarify, and I did say this in the last webinar, and I got further clarification on this, that the program is not required to itemize the 33 hours of CME. So I just want to make sure that that information was relayed. And I'll have this on the clarification document as well. More updates about CME. All critical care CME counts. Again, that was a change from the clarification document in September, where we only allowed a certain percentage. So all CME counts. Internal education process time must be equivalent to 16 hours annually or 48 hours in 3 years. Must be trauma or critical care medicine related. We do not want to see any CMEs on cancer. It's just not accepted. And then the new thing that came out of the CME or from our VRC meeting was the proration. I know I've had a lot of questions about prorating CMEs, and we were a little nebulous on that only because we didn't have a benchmark or we didn't have an hour. So what we did is it's still accepted. We still prorate it. We still are accepting that for new trauma centers and new physicians. The only difference is that now we've established that it's got to be 16 hours annually for those new centers or new physicians that have been on the service for, say, a year. Excuse me. Peer review attendance for combined programs. This is a change also from the clarification document. So for those combined centers that had to meet the attendance requirement for both the adult program and the pediatric program, we have now made a modification to this that there must be a representative, either the trauma medical director or designee, could be the trauma program manager or the predetermined person, from the adult program or from the pediatric program may attend the other program meetings and ensure that that dissemination of communication is sent to the other panel members. So what that means is that the adult trauma program manager or the trauma medical director can go ahead and attend in place of all the other specialties at the pediatric program committee meeting. And the same would be true for the pediatric program. So it's a change from what we've been doing, and this again will be on the clarification document. Exemptions, we do have this on the clarification document, but I do want to say that we added missionary work to this category. So an exemption is permitted for surgeons or physicians who are on active military deployment, medical leave, or missionary work. The trauma center must have documentation in the form of a letter to support the absence. So if you have a visit coming up in the next year or a year from now and you know your physician is going to be deployed or on medical leave or missionary work, we do expect you to provide a letter to support that absence. One of the things that is discussed often is the ICU director, and again, this is a new change, and this again will be on the December clarification document. It's not in the current document, but it's going to be in the December one. In a level 1 trauma center, a surgeon with current board certification in surgical critical care must be designated the ICU director. So we have now clarified this with the committee's approval that if the trauma medical director meets the above requirements, that being a board certified in general surgery and also in surgical critical care, then she or he may fulfill both roles. So that is acceptable, and that's in line with the level 2 and the level 3 trauma center or clarification document as well. Outreach activity, I just want to bring this back around that the Stop to Bleed may be used as an outreach and education activity for those centers that are looking for some additional education. BD-related questions. So meeting requirements following updates. So currently, question from a level 1 pediatric trauma center, will trauma centers be responsible for clarification documents updates once the PRQ has been submitted? That means that they've submitted their PRQ and it's closed. They can't make any more changes to it. And this is primarily done 30 days before the site visit. The answer is no. The center will not be held to the new updates that are released after their PRQ has been submitted. Just know that in September we released that, or not September, October, November released some updates. You're not going to be held to the same standards. If there's any questions about that, again, please feel free to email me directly at the COTVRC@FACS.org. Question about trauma tier activation response times. So the question from the level 2 trauma center is the response time from patient arrival for only the highest activation, or does it also include the partial activations as well? And it's for both. So for you to track your trauma surgeon's response time for when they need to be there for the highest tier or for the partial activation, you want to go ahead and track that from when the patient from the patient's arrival time. Trauma team activation. Question about, they heard something at the TQuip conference that it's okay to activate after arrival, after a patient's arrival, as long as it's within the first hour. Is that true? So I've never heard about the first hour, but what I want to say about this is a patient may be activated after they arrive to the ED. For example, if the patient did not arrive as a trauma team activation, they were either dropped off or it just wasn't called from the field that they had to be activated. But after the patient's been evaluated and determined to meet the trauma tier activation, whether it's your highest or your second tier, then you can go ahead and trigger or call the activation at that point in time. If that is the case, then the trauma attending's response time will be tracked from that time, from when it was called or triggered, if you will. Direct physician-to-physician contact. Questions come up often. What is meant by physician-to-physician response time? Most facilities have transfer call centers who take the info, and this is very true. So in most trauma centers, if a patient is being transferred, there has to be some communication between the transferring facility and the receiving facility's ED physician and or the trauma surgeon. So there has to be some communication there for them to accept the patient. Oftentimes, if that's not done, you run into the possibility of not having enough room or beds available for receiving that patient, or the surgeon or the specialty needed not available. So there has to be some communication about that within the two. There are some states that have referral centers, and that's acceptable as long as they've been credentialed to do or relay the communication to the ED physician or trauma surgeon. We currently have a pilot program that we are working or overseeing, rather, that is going to look into this and whether advanced practice providers could be used in lieu of the ED physician and trauma surgeon. So more to come on that as that it rolls out and unfolds. Examples of 30-minute response times for neurosurgery. You know, we're not looking for these specific types of injuries, but these are some. So penetrating injury to the head would alter mental status, TBI with emergent surgical intervention, TBI with emergent EVG monitoring, Again, these are just a few. As a trauma center, as your own institution, you can go ahead and determine what additional, if any, injuries you want the neurosurgeon to respond to within the 30-minute time frame. Neurosurgery call schedule. So this is from a level 3 trauma center who is looking to become a level 2 trauma center. They use designation. We don't designate, we verify. And their question is it acceptable for the on-call neurosurgeon to perform surgical cases at another facility if there is a published backup neurosurgery call schedule? Yes. If there is one neurosurgeon that covers 2 facilities within the same geographical location, they're in the same town, you know, maybe east, west, north, south, or even down the street, there must be a published backup call schedule. So there has to be a call schedule in place. Question about OR availability. So this is from a level 1 trauma center. An operating room must be adequately staffed within 15 minutes. And this is met by having a team in-house. If the operating room is occupied, an adequately staffed additional room must be available. Does the second call team need to be available within 15 minutes as well? No. It is true that for the first team, we expect 15 minutes response time, and the best way to meet that is by having them in-house. But we don't have a defined time for when the second OR team, or you can refer to them as the backup team, must respond. We will allow the institution to determine what that response time is and to monitor that through their TIPS process for any delays. From a level 2 trauma center asking about anesthesiologist backup. So the question is, for anesthesia response in the event of a second trauma requiring surgical intervention with regard to time, the backup anesthesiologist has 30 minutes to arrive, so it's acceptable for a CRNA to start a case while the in-house anesthesiologist is encumbered. Absolutely, that is acceptable, and that's also in our manual. So when you are using, say, an anesthesiologist, senior resident, or a CRNA to start, the requirement is that you must have, or you must advise and have the anesthesiologist respond within 30 minutes, and they must be present for all of our operations. So again, that is in CD 11-5. Peer review attendance for anesthesia and radiology. Hopefully this slide can clarify some of the confusion. So the expectation or the requirement, if you will, is for level 1, level 2, and level 3 trauma centers, the anesthesiologist and or predetermined liaison or other physician must attend a minimum of 50% of the trauma peer meetings. For a level 1 and a level 2 trauma center, radiology, radiologist liaison and or predetermined physician must attend a minimum of 50%. So it's a little different for level 3. They're not required to have the radiologist attend their meetings. Peer review attendance. Question is, are there guidelines for the number of times teleconference can be used to meet the 50% attendance for peer review? We don't have a line in the sand, if you will. What we've been telling trauma centers is that the expectation is that teleconferencing to be used on a limited basis. And again, this would factor into your institution's process as far as, you know, sharing information outside of the hospital. So I'm sure there's some, if there's some firewalls that they need to clear, we're going to let the institution determine the frequency for allowing that. Peer review attendance. Do resident liaison require the same 50% peer review attendance? So this was a little confusing for me, but I think because we don't use residents liaison, we don't use that terminology. So if I'm not answering the question in this slide, please reach out to me directly, and I will go ahead and address your question. At a level 1, level 2, and level 3 trauma center, all appointed liaisons must be a surgeon for the required specialties. So neural trauma, trauma is the medical director, neuro ortho. For emergency medicine, anesthesia, radiology, it must be a physician. I've had some questions asked if it could be a CRNA or if it could be the nurse sent in place of those folks, and the answer is no. All trauma surgeons on a trauma panel must attend 50% of the trauma peer review meeting. Operating room backup team. Question from a level 2. What is the expectation regarding who should be covering the case for when the backup team was called in? Should the in-house team continue the trauma case and the backup team remain available for potential incoming cases? Or is the backup team expected to take over the trauma case to allow the in-house team to be available for additional incoming cases? So I know there's a lot of questions in this slide, and what I think is being asked is if the first OR team is encumbered or on a case, they're currently on a case, and the second team is called because there's an impending case coming, then the second backup team or the second OR team, which is the backup team, must move forward with that case they were called for. So if the second OR team was called in for a trauma case because the in-house team is encumbered, the expectation is that the backup team should cover the trauma case they were called in for. So they don't need to step aside so the first OR team can oversee that case. Operating room availability. Define level 3 OR staffing expectations during off shifts on-site staff versus on-call. So in a level 3 trauma center, an operating room must be adequately staffed and available within 30 minutes. A backup OR team is not required. So if there's a CRNA in-house and a tech or a scrub tech in-house, they can start the process or prep the room, if you will, while they're waiting for the anesthesiologist to respond within 30 minutes. If an on-call team is used, timeliness must be ensured to start operations. Response is continuously monitored through the TIPS process. There must be measures implemented to ensure optimal care for those cases. ICU coverage. I've had this question come up a couple of times. What they're asking is CD 1151. Appropriately trained physicians must be available in-house within 15 minutes to provide care for the ICU patients 24/7. It's a type 1, so if this is not being done, a trauma center can lose their verification because it's a type 1. In all level 1, 2, and 3 centers, the timely response of potential providers to ICU must be continuously monitored as part of the TIPS process. Is the intent here that this bedside nurse starts to document response times of providers to pages akin to the response time of ortho and neuro to the ED for specific conditions, time to call back, time to bedside, only in critical conditions? So the intent is for the attending or the credential provider, whoever that may be in your trauma center, to respond within 15 minutes for any critical situations that that presents itself in the ICU for that patient, and that information is tracked and documented. Any delays that impact the care would be reviewed through the TIPS process. So there must be clear documentation about this. And there was a slide that I talked about what this looks like a little bit earlier. CME for ICU. For level 2 trauma centers, our intensivists working in the ICU are required to have 16 hours of trauma-related CME. The answer is we don't have any specific requirements around intensivists. What we expect or what we like to see is if the intensivists are used to provide coverage for trauma patients in the ICU, that they are expected to meet the same standards as the other surgeons, such as participate in the internal education program, or if they have external CME. Now that we count critical care CMEs as trauma-related, they can use that to meet the requirements. Question about blood bank, and this is from a level 3 trauma center about having red blood cells available within 15 minutes, and several questions on this. So the question is, does this need to be thawed and be at bedside within 15 minutes, or does this mean available and being thawed? And the answer is yes. So you're not required, the level 3 trauma center, you are not required to have this thawed. You can start the process of thawing out the blood cells or the red blood cells and frozen plasma, you know, within that 15 minutes, but it's not expected to have it there within the 15 minutes. But it must be available when it's requested. So a level 3 trauma center should have a process in place to ensure platelets and fresh frozen plasma are available in a timely fashion. And we're not defining that timely fashion. So again, if it's frozen, you can begin the process, but we're not expecting it to be thawed out within 15 minutes. Pediatric trauma program managers. I brought this back around. This actually was a question from our last webinar, and I think there was some confusion. And what I want to say about that, my response is going to be primarily to that specific trauma center. So I did get quite a few emails after that. So the question was, is a pediatric trauma manager necessary in a level 2 pediatric trauma center? And hopefully this slide will clarify that. In a level 2 trauma center that are freestanding, meaning separate from another level 1, level 2 trauma center, there must be a dedicated pediatric TPM. This person may serve as the injury prevention or performance improvement coordinator. However, they cannot serve as the registrar as well. So that's a clarification. In a combined level 2 adult trauma center with a level 2 pediatric trauma center, a separate dedicated pediatric trauma program manager is not required. Registrar requirements, how strict are the registrar guidelines? We're pretty strict on that, so we do hold trauma centers to the standard. To see a detail of what those description or the description of the requirements are, please refer to page 112 in the resources manual. Again, question about the FTE requirement for a trauma center that has a 0.8 registrar for 500 patients entered on I think that meant regularly or registry and other expected duties. So the expectation is 1 full-time equivalent employee dedicated to registry must be available to process data capture for the NTDS data set for each 500 to 750 admitted patients annually. So what I want to say about this is additional tasks for the registrar may include, but are not limited to, this list here. Again, refer to page 112 of the resources manual. Running reports, validating data, NTDB, TQuip data submission, etc. These other functions may impact how the registrar's ability to perform other duties outside of the registry. Prorated CME for pediatric, and this would be true for any trauma center. So the question came from a level, the pediatric trauma center, first ACS site visitor, members who are new to the trauma service for verified trauma centers. CME may be prorated. How will you handle prorating for centers like us who are undergoing our first pediatric site visit? Again, looking at this trauma center, they're anywhere from a year to 2 years that they were appointed to the service. So there's going to be some CME to those trauma surgeons and physicians. So the prorated requirement for new trauma centers or anyone new to the service will be prorated for 1 year as 16 hours of external trauma-related CME. The prorated amount will vary based on when the physician was hired. So if that is the situation at your trauma center, let's say, and I'm going to have this on the next slide, it will then be prorated further from the 16 hours. So for example, if there is a new physician who started, say, July, in this slide, if someone's using a reporting period from, say, January 2016 to January 2017, whereby a physician was hired in July, it's going to be expected that the physician or surgeon has CME, and it's going to get prorated further. So if you're a new trauma center coming on and been preparing for your site visit, then we're going to expect you to be have 16 hours of CME for that reporting year as you're preparing for your site visit. Research alternate criteria, question about what do we constitute as national or regional, and defining what that means. Does it mean state level? Actually, we're counting for ACS purposes, recognized regional or national organizations are defined as the American College of Surgeons, the Eastern Association for Surgery of Trauma, the American Association for Surgery of Trauma, the Western Trauma Association, Pediatric Trauma Society, etc. So those are what we call national and regional organizations. So I'd like to take this opportunity to thank you all for your participation. If anyone has any questions on anything that I've presented or any questions for our next webinar that's going to be holding here in January, please email us at the cotvRC@facs.org. Again, I appreciate your feedback and look forward to presenting in January. Thank you.
Thank you, Trauma Verification staff, and thank you to everyone for attending today's webinar, Trauma Verification's December Q&A Web Conference. If you have any other questions, please contact cotvRC@facs.org. Trauma Verification and our presenters, thank you for joining us today and have a great rest of your day.